the day 2 of 19th Annual Conference of North Zone Association of Plastic Surgeons. Today's session is session 7, and I would like to invite the chairperson, Dr. Pinky Pargal, Dr. Kuldeep Singh, Dr. Bhupender Singh to come on the stage and chairing this session.
I would like to thank Dr. Rakesh, Dr. Tyagi, and all the North Zone team for inviting me to give my talk on hyperbaric oxygen therapy for second-degree burn wound healing, aesthetic and hearing loss. I was supposed to talk on this topic as in the scientific program. Dr. Vishal Mango was there, so I have not included. Little bit basic I have added in the morning. The hyperbaric oxygen therapy has recently gained the publicity over 10 years. There are only few centers in India. It is defined as inhalation of 100% oxygen while in a treatment chamber where the pressure is increased more than 1 atmospheric pressure. It enhances the solubility of oxygen in blood and other body fluids as much as 5 to 6 ml dissolved oxygen per 100 ml of the blood at 3 atmospheric pressure. The hyperbaric oxygen was first recommended by Valenzuela as a treatment for bacterial infection. Initially, it was used for decompressive illness. So, use of hyperbaric oxygen therapy is emerging beyond the limits and beyond the specialties. In the modern era, there are numerous indications of hyperbaric oxygen therapy which are approved by Undersea and Hyperbaric Medicine Society and British Hyperbaric Association. Certain indications, as I said, it was started for the decompressive air embolism, then arterial insufficiencies, necrotizing fasciitis, compartment syndrome, burn injuries, sensory neural hearing loss, aesthetic, carbon monoxide poisoning, compromised graft and flaps, crush injury, chronic osteomyelitis, radiation-induced damage, sports injuries, and gynecology problems. There are certain contraindications to do the hyperbaric oxygen therapy. There is untreated pneumothorax, sinus infection, upper respiratory infection, pulmonary lesions on chest X-ray, high fever, history of chest or ear surgery, any convulsion disorder, middle ear infection, pregnancy, acute hypoglycemia. Absolute contraindication is untreated pneumothorax. Relative contraindication includes pregnancy, emphysema, URI, optic neuritis, and ear problems. One should do screening before the session, should a detailed examination, and most important is ENT evaluation to be done for ear tympanic membrane also. Then pre-anesthetic checkup should be done. Rule out contraindication which have I listed. Then any psychiatric illness to be ruled out. Then vital monitoring is done, patient comfort is seen, when the patient has a last meal, clothing. Post-session evaluation, after the patient should be observed for 15 to 30 minutes for vital monitoring, especially earache and headache. These are the chambers. There are two types of chamber. One is mono chamber, one is multi chamber. These both types are available in our department. One is this is single chamber in which one single patient lies, and this is chamber enclosed in chamber. There is window, and there is chamber. In this we have 2 chairs and 1 stretcher where patient can be treated. This is how the patient lies and get treatment. This is mono chamber. This is the machine outside line. You can observe there is a video recording also. You can see what the patient is doing. The patient can hear the music inside. And this is the multi-chamber. The patient can lie, and 2 patients can see like this, opposite side. So my topic was burn. So we have done the hyperbaric oxygen burn wound was initiated in 1965. And recent work in rat models has shown that hyperbaric oxygen therapy reduces healing time and improves scar appearance in burn study. So we have done a study, with case control study, in which there were 2 arms, in which one group was given hyperbaric therapy and one group was on conventional treatment. aim was to determine the effect of hyperbaric therapy on second degree burn wound healing with the objective of selective feature burn wound healing by assessing inflammation, angiogenesis and epithelialization by doing the biopsy. So inclusion criteria were patient with second degree thermal burn involving up to 30%. We have not taken more than 30% surface area. Then patient aged between 18 to 60. And exclusion criteria were electrical injury, chemical and other type of deep injuries. Patient with immune deficiency diseases, untreated pneumothorax, seizure disorder, CHF, and eustachian tube, ear problems. So this is a randomized control study. We done it 2021 to 2022. This was institutional ethical clearance was taken, and group A was included 16 patients and group B included 16 patients, and biopsy was taken on day 0, 4, 8 and 12. These are the group. Then assessment parameters we included: regeneration of basement membrane of epithelium, number of inflammatory cells per high power field, and number of microvascular per high power field. These are the some of the patient at that time and the day 12. These are patients which were taken, and these are after day 12 and at the time of admission in day 12. This is another patient at the time of presentation and at the time of day 12. What we have seen in group A, where the hyperbaric oxygen was given, that monocytes were less and monocytes were more on the, this is our slides done by our pathologist, and monocytes were more on the patient treated on conventional therapy. Then basal layer regeneration was more on group A, hyperbaric oxygen patients, and nevascularization also more. In that control group, it was less. This showing the same thing. Then histopathology, I have shown the hyperbaric oxygen therapy. Patients have few inflammatory cells and increased angiogenesis and more epithelialization compared to group B. This is same. Then hyperbaric oxygen therapy increases the oxygen gradient between the center and periphery, thus wound creating a strong angiogenic stimulus. Angiogenic stimulus along with fibroblastic proliferation leads to increased neovascularization. This study shows increased neovascularization in the hyperbaric therapy. The next group of patients were hearing loss. There are two types of hearing loss. One is conductive hearing loss versus sensory neural hearing loss. So in sensory neural hearing loss, these patients were benefited by this. We have treated around 25 patients. Now we are conducting the case control study. Then when the result comes, I will present in the future. Then hyperbaric, how it helps. Hyperbaric oxygen increases the oxygen tension in the lymph space via labyrinthine arteries, which reverts the pathological changes. Any arterial pathology like sclerosis, stenosis, obstruction, compression may alter its efficacy. So what we are doing, we are giving a trial. In every patient, we are giving a trial for 15 to 20 minutes. If the patient tolerates, then we go for the sessions. We increase slowly from 1.5 atmosphere pressure to 2.5 atmosphere pressure. We give for 60 minutes, and the duration of session also increased gradually. Then patient was subjected to the treatment on OPD basis. Patient comes, and minimum at least for 6 weeks and up to maximum 3 months we have taken. And in this, these are followed by audiometry test, which shows the improvement in the hearing. Then coming to the aesthetics, for people like to be young and look young and stop, try to delay the aging process. So few methods are available. People follow. One is physical exercise, intermittent fasting, plasma transfusion, stem cell therapy, and xenotherapeutics. So no sufficiency effective alone, not sufficient. These by exercises, certain degree of invasiveness is required, then stem cell therapy and EM plasma. So the advantages of hyperbaric as a novel therapy for healthy aging include its non-invasiveness, established safety profile, and common clinical application in diverse population. How it helps? It helps by angiogenesis enhancement, immunomodulatory properties, elevation of antioxidant activity, suppression of cellular senescence, and stem cell regulation. This is taken from one paper which he has explained this therapeutic implication of hyperbaric oxygen therapy in aging intervention. He says it helps in improves the cognitive improvement by brain, alertness increases, heart and lung, myocardial and pulmonary function improvement, skin improves by inhibition of intrinsic aging and photoaging, skeletal muscle oxidative capacity increase, inhibition of muscle loss, bone and inhibition of bone loss. This is another explained by the paper by Bralipost. He said the ultraviolet rays and they create H1 alpha and VEGF factors, then neutrophils, elastase. These all increase in wrinkles. The hyperoxia given or attained by the hyperbaric oxygen therapy, this stops this pathway and delays the wrinkling. This is another paper by hyperbaric oxygen therapy for healthy aging from mechanism to therapeutics by Fu. He said hyperbaric oxygen goes through blood and increases the actually helps at the mitochondrial level. Mitochondrial metabolism is affected and mitochondrial biogenesis increases, which acts as a scavenger, so leads to less wrinkling and less aging is delayed. This is another paper, the effective hyperaging oxygen therapy on pathophysiology. He has studied histopathologically the improvements by hyperoxygen therapy on by doing the biopsy. So he said that baseline elastic fiber, there was a significant increase in number of elastin fibers after giving the hyperbaric oxygen therapy. The elastin fibers were less initially, then after therapy the number increases. So the wrinkling is delayed. Then papillary thickness, he has studied that following hyperbaric there was significant decrease in the papillary thickness. Then senescence cell changes, he has said that there was significant decrease in number of senescent cells. These are all supported by the pathology in his paper. Then we studied, the case control study with hyperbaric oxygen, chemical peeling and Botox. So we took this study, though all the number was less, but we are increasing the numbers. So our aim was to evaluate the role of effective hyperoxygen therapy in attenuating or reversing the signs of aging, to compare the hyperbaric oxygen traditional modalities as botulinum toxin, Botox and peels. So we have included, we have got institutional clearance from Institutional Ethical Committee and CTRI trial we have registered, then we have done this. Inclusion criteria were healthy male or females between 30 to 50 years and willing to undergo the intensive aesthetic procedures. Then participation, as said, there are 3 groups. One group was given chemical peeling, one group was given Botox, and one group was given hyperbaric oxygen therapy. We have studied with the dermoscopic photoaging scale. There is a photoaging scale, we have monitored on that. And these are the scales which have seen yellow discoloration, yellow line. These are the things we have studied with the dermoscopy. And so, treatment results showed that the DPS score improved from 4.5 to 2.7 in the hyperbaric, and at the cheek from 4.3 to 2.6, and also on the chin it is improved. So these are the patients which were subjected to the hyperbaric oxygen therapy. The wrinkling was improved a little bit. So we have given 60 cycles. Then these were the group of chemical peeling. As you know, chemical peeling results. One can say don't compare orange with apple, but we have to see certain features like wrinkling or discoloration. So we have done this study. And comparison wise, when we compared with the chemical peel treatment, significant improvement was there in DPS on the hyperbaric, and slight improvement in chemical peeling was there. So this is Botox group. So comparison with Botox group, we have seen the hyperbaric oxygen therapy showed significant improvement in hypopigmentation, hyperpigmentation and atelectasia. In superficial wrinkles, both group have shown the significant reduction, crisscross wrinkles, in crisscross and deep wrinkles, the botox results were better than hyperbaric oxygen therapy. So this was patient satisfaction group. The patient were hyperbaric oxygen therapy were more satisfied, chemical peeling was less satisfied, and botox was almost equally satisfied. So this we have conducted this study. This study needs further number of cases to be done. We are increasing the numbers and doing continuing. So how hyperbaric oxygen therapy for anti-aging is helpful? At cellular level, hyperbaric oxygen therapy increases oxygen delivery to skin, cells promoting cellular health and regeneration, enhanced oxygen levels stimulate collagen production, improves skin elasticity and reducing wrinkles, and hyperbaric oxygen therapy helps in reducing hyperpigmentation leading to more even skin tone. So how actually we have, I was given to present on these three only, but we are, as Vishal is not there, so we have increased this, we are doing for non-healing ulcers, and especially it is very helpful in treating the post-radiation injury cases, post-radiotherapy patients in our cases. So these are the how other clinical application is done. Hyperoxygen CO poisoning, as I told in beginning, to how it is done. Thank you very much for your patient hearing. I invite you for attending National One Conference Nzapscon at Ayodhya, which we are organizing from 13th, 14th, 15th of February, which you can add with your Mahakumbh visit, which is hardly 150-160 kilometers away from Ayodhya. I welcome you there, and thank you very much. Any questions I would like to happy to reply.
Thank you, sir, for nice presentation. We can have questions, one or two, if we have.
Actually, cost-wise, now it is costing around 1.5 crores to 2 crores, because we have got aid from NTPC under CSR for burns. So we purchased one machine, multi-chamber there. But it is very helpful. It is coming. People are more moving to hyperbaric for aesthetic reasons also. We are getting a lot of calls, and especially in the post-radiation therapy injuries and hearing loss. It is very helpful. Thank you very much.
Thank you, sir. May we invite now Dr. Ankur Bhatia.
He's not come.
Respected chairpersons and dear colleagues, so I'm going to talk about Q-switch anti-ag laser, a versatile tool. So this is one technology about which it was said that this should you get some other technologies and then add it later on. But nowadays we are seeing that is one of the technologies which should any aesthetic center should get in the beginning. So I'll explain the reasons why. So basically the source is the NdAg laser, and NdAg means the neodymium doped deuterium aluminium. It's a tongue twister aluminium garnet laser. So this is all lasers are basically named on their source, and typically there's a NdAg rod, and around it there's a flash tube in which there's a flash lamp, and this flash lamp creates the energy for the laser generation. And why NdAg? We don't use ruby or alexandrite Q-switch in India, because the NdAg is safe for darker skin types and it penetrates deeper than diode and alexandrite, and so we are using the frequency doubled Q-switch NdAg laser. And how the frequency is doubled? There's a frequency doubling crystal. So once the frequency is doubled, the wavelength is halved. And the Q-switch is basically, it's like just like we have a camera, and we have a camera with the high shutter speed. So it is like the switch briefly opens and allows a pulse of high intensity, very low pulse duration, that is in the nanoseconds. So this is the diagram showing the depth of penetration of different wavelengths, and as we can see, the NDI penetrates the most, and the 532 penetrates just beyond the epidermis, and that is why the 532 is usually used for the epidermal and superficial lesions, and the NDA 1064 is used for the deeper lesions and dermal lesions. So basically we can use a collimated beam here, which is collimated beam is like it is at the, even if we fire at 2 kilometers away, the intensity will be the same, and the focused beam, which is focused at a certain distance. So nowadays most machines, they have collimated beam from 8 to 10 mm, which we can use for carbon peeling, because in carbon peeling, if we take the handpiece too near, there will be the flying particles, they will soil the aperture, and mostly the focused beam is used for most indications. This is another technology. So initially all the machines were Gaussian beam. Gaussian beam means that there is a more energy in the center, there is a sudden burst of energy, and nowadays the most machines are top hat machines. Top hat machines, that means there's a uniform delivery of energy and there's no sudden surge. But the Gaussian beam scores where there are deeper tattoos. So nowadays there are some machines which have got a separate Gaussian beam handpiece for tackling the difficult to treat tattoos. So nowadays we have two types of machines: Q switch NDI laser, which gives pulse in nanoseconds, that is 10 is to minus 9 power, and there is the pico laser, which is having pulse in picosecond, 10 is to minus 12 seconds. But there are very few pico machines in the country and they are very costly, so most centers are not able to afford, and there are only advantages basically in some tattoos where they score over the Q switch NDI laser. So pico laser is also NDI, but pulse is in picoseconds. So in pico laser, the photomechanical effect is more than the photothermal, whereas in Q switch NDI, the photothermal effect is more. And so according to the theory of selective photothermolysis, on which most laser treatments are based, the light of a specific wavelength is absorbed in a chromophore, and the pulse duration should be less than the thermal relaxation of time of the chromophore. So that is how the energy will be retained, and then that is how the chromophore will be destroyed, and sufficient friends should reach the chromophore. So TRT is basically the time for a target to release more than half of the temperature rise, and so pulse width should be less than the TRT. So then the energy will be contained in the tissue, and the critical heating point will be reached. So if we see the structure of a melanocyte, the melanozymes are organelles inside the melanocyte, and melanocytes are mainly concentrated at the dermoepidermal junction, but in different pathologies they may become superficial or deeper. And the target for the pigmentary lesions, so melanosomes have a TRT of 20 to 40 nanoseconds. That is why the long pulse NDI, which is not Q switch, will not work well for the pigmented lesions. And tattoo particles have a TRT of 20 nanoseconds to 3 milliseconds. So this is the reason why the lightening procedures, most of them they are temporary. When lot of cases will come for lightening or whitening of the skin, and so we have to explain to them that melanocytes are a dynamic structure. Even if that there is nothing like some ink or any pigment is lying in the skin. So even if you suppress the melanocytes, often they will bounce back after a while. So that is why even glutathione IV drip, after we stop it, mostly the skin reverts to our the hue of the skin which has been we have got by birth or by our genetics. And so the effects of Q switch anti-egg laser can be photothermal, vaporization, and photomechanical. So photomechanical effect is basically it is more suitable for this concept is more suitable when we are treating tattoos, and it creates pressure waves in the tissues leading to fragmentation of the target. So picosecond laser is especially useful in resistant tattoos where the particles have a stress transition time of less than 1 nanoseconds. So we have a instead of TRT we have a concept of SRT, that is a stress relaxation time. So interestingly, nowadays the most use of the Q switched anti-egg laser is not for treating pigmentary lesions and tattoos. The maximum used is for the laser toning. So that is how the economy of the machine will work out. So for the nowadays the devices have this special technology called PTP, that is a photoacoustic technology or photoacoustic twin pulse. So here two pulses are given in quick succession. So there is less of downtime, irritation, redness, while the effect is the same. So here normally we use 6, 8 or 10 mm spot size in various combinations. Very important. So the Q switch anti-egg laser is like an infant. Lot of care has to be taken for this machine. Preferably it should be put on every day. And it should not be moved in different centers because it's a very delicate balance of the various lenses inside. And even in the while moving around in the clinic, they should not third or sometimes there's a step from one room to other. So even there we should be very careful, and laser aperture to be cleaned after every treatment, because if we don't clean it, it will get cracked because the particles they will act as a chromophores which deposit, and also the energy delivery to the target will be less. For doing carbon peeling or for doing tattoos, we must have a smoke evacuator or exhaust in the treatment room, and regular service every 3 to 6 months depending upon the usage. So what is the typical endpoint? As you can see in the diagram, it is frosting without bleeding. So if we are having bleeding, that means we are giving either excessive fluence or we are giving too low a spot size. So this frosting occurs because of the micro bubbles of steam formed by disintegration of melanosomes, and usually it goes away in around 20 minutes. So there are some superficial lesions which are easily amenable to Q switch anti-egg laser, and these include the freckles. So freckles in fairer skin types we use 532 and darker skin types we use 1064. Then solar lenticle antigens and nevus pilus. So this is a case of freckles, excellent result obtained, and usually we need just 1 or 2 sittings, and then after 3-4 years we may need a maintenance. Of course, lifelong sunscreen is required. So this is a case of nevus pilus. The client was quite satisfied, more than 80% result is there. Then the congenital dermal lesions like nevus of aorta and nevus of I2. Nevus of I2 is basically nevus of aorta in the body, and nevus of aorta is in the facial areas. And nevus of aorta has special cells, they are known as nevus cell. So they are the type of nevus cell nevi. So 6 to 10 sittings, we should keep a good interval, at least around 2 months, for the tissues to recover. Otherwise, we will get PIH because of the laser. So this is a case of nevus of aorta. Near complete clearance was achieved after around 7 sittings. And of course, we can't do in the eye, but we have to be careful, and that these cases are prone to have glaucoma, and we should always tell them to get eye checkup regularly. And poor results in Becker's nevus and Caffulae spots. And Caffulae spots especially, we should be careful about that. We should not miss neurofibromatosis. And The Bacchus nevus, as you can see, are commonly found on the shoulder with the hair, and it's basically a hematoma and requires multimodal therapy and purely Q-switch and melanocytic nevus also there are variable results, and the best treatment for melanocytic nevus is surgical. Like we excise or resurface this nevus and apply cover in either in form of split thickness, full thickness, or use an expander or use a flap. And again, guarded prognosis is lichen planus pigmentosus and amyloidosis, because they are basically dermatological conditions and they should be first treated as such. And then a very good weapon in our hands is the test patch. Suppose you are doubtful about any lesion, instead of doing the whole area, we can do a test patch and see the result. We can even do 2 test patches in a sequence. And while treating nevi, especially in those who are above 40 years of age, we should rule out malignant melanoma. So there are melanocytic nevi, basically 4 types: lentigo, juxtal compound, and dermal. And the commonly what we see as mole is the compound nevus. And in the mixed lesions, which are especially melasma and post-inflammatory hyperpigmentation, again it requires multimodal therapy and never give without priming. That is a course of depigmenting agents and sunscreen, and only preferably toning dose should be given. We should not give high fluence in these conditions because they may worsen. So coming to the skin rejuvenation and toning, so this is the most common indication nowadays. So this is one laser which can be kept in an institution as well as in an aesthetic center. So it works well in both. So for skin rejuvenation, we can do carbon peeling, we can use PTP mode, we can use Genesis mode. There is also a temporary reduction of fine hair on the face. And for those who are allergic to bleach, it causes a very nice laser bleach, and that goes quite deep. So it can be used very well, offered as a pre-bridal package. One of the best modalities for offering as a pre-bridal package. So I have listed the various modalities of skin toning and glow. So see, there are around 16 to 20 modalities with which you can give a glow in an aesthetic center. But the Q-switch NDX scores over the most of these modalities for the reason that there is no downtime with the toning dose. It is non-invasive and there is a good effect. So there is a lot of clients are afraid of needles and injections and invasive therapies, and for them it's they are very comfortable with the Q-switch NDX laser. So in laser toning, typically 2-3 passes with various combinations of spot size to 6 to 8 mm. Some are using 10 mm. Also, frosting is to be avoided. So here, if you are getting frosting while laser toning, that means we have giving excessive fluence. Endpoint is slight erythema. This may or may not be there. The client will tell you that I am having slight burning, and that's it. That is how you judge that you are giving adequate fluence. And pre-bridal is toning plus laser bleach, and carbon peel I'll explain in detail. So this has also become very popular, and it is in the social media also, carbon peel. And normally in laser toning we give 3 to 5 sittings at the interval of every 3 weeks, and then we can continue maintenance as 1 sitting every 3 to 6 months.
Sir, you conclude faster.
So laser toning, this is an immediate result. Then laser toning long-term result. So quasi-long pulse is very important. It's a Genesis mode. The pulse width is in microseconds. The major effect in microvascularization, we can very effective for open pores, rosacea, erythema, and for fine wrinkles. Carbon peeling, we apply a thin emulsion of carbon, and then we remove it, and second pass we give like a normal toning. And combinations, quasi-long pulse, two passes, different spot sizes, we can mix different combinations depending on what is the requirement of the client. And treatment of tattoos, here also we should achieve frosting, and so we should try to avoid taking that cases with professional tattoos or multicolored tattoos. Sometimes you will be in a soup once you take up that case. So best is that amateur tattoos which have got a carbon ink in that, and results are rarely 100% in the Indian skin. And caution and avoid, especially so that the white tattoos have titanium dioxide that may even darken with the laser. So titration of dose, start with the low fluence. So even if your machine is not giving the proper power, with titration we can achieve the clinical endpoint. So titration is more important than seeing the parameters on the laser. And once the lesion becomes lighter, it increase the fluence. And in laser toning, it's okay, you know by experience. So PIH can be there with the lasers. Again, treatment again is a low dose laser. Hypopigmentation, so this is, if you give high fluence at very low spot size, you can have a hypopigmentation. So in conclusion, Q-switched NDX laser is a must have in an aesthetic surgery or cosmetology center. However, the device requires regular maintenance and delicate handling, and results and safety depend upon the operator as well as the quality of the device. Thank you very much for your attention.
Thank you, sir, for your nice presentations. Sir, any questions? We will move on to next speaker. Thank you very much. The next speaker is Dr. Vikas Gauri.
So uses of fat grafting. So my topic is for the breast augmentation, the cosmetic. So if you want a modest increase, just half cup size or to 1 cup size if you do 2 sittings, and if the client wishes to avoid the implant. Second is the breast asymmetries. Usually if there is any asymmetry in the size of post procedure. Third is after breast reconstruction, after the breast cancer surgery. And last is again the part of aesthetic, that is post-implant refinements. We can camouflage the visible implant edges. So it has got a natural look and feel, so dual benefit. This is to be highlighted because the patient is benefited from the liposuction also. So no foreign material, minimal scarring, and the results are subtle. So what are the cons? The limited volume increase, then there is a fat absorption. So this is the problem, it is very unpredictable. So we always calculate the 30% on an average in the procedure which I follow. So it is not for everyone. Again, the con, you should have fat in the body. Unpredictable results, longer procedure because it involves 2 procedures. So breast implants, we can skip this. Breast implants, we can get the dramatic increase in the size. The results can be long lasting, predictable, but it is an invasive surgery with the scar. Then there are risk of complications, then scarring, maintenance maybe after 10 to 15 years, and less natural feel. So this is the result. This is 38 years female, a single session, 350 ml of the processed fat, and this is the long result, long time result. This is just 200 ml. So this is my OPD. So what are the questions mostly I want to address, that how we can predict the survival rate. So this is the most difficult to predict. Then the choice of the donor area, will it affect the survival? Which technique should be used to harvest? How should graft be prepared to achieve the maximum survival? and which is the best injection technique? Or does the fat grafting increases the risk of breast cancer? Do fat graft mask the malignant lesions radiologically? Is there any way to distinguish microcalcification from breast cancer on mammography? And do adipose stem cells, they carry the hope for the future? So what is the method? So we can use preferably any liposuction device, but mostly what I learned is by the water jet liposuction. So I perform under GA, but in the actual Bewley protocol, it is done under sedation and local anesthesia. So liposuction areas preferably are abdomen, flanks and thighs, but it is always according to the wish of the patient. So what is the infiltration? It is very typical, 1000 ml of normal saline with 25 ml of 2% lignocaine and 1 ml of 1:1000 concentration with some soda bicarb. This solution is always pre-warmed, and the liposuction, especially in the body jet, does not need any waiting period, so we can avoid 15 minutes of waiting. So we start the liposuction immediately. So this is how it works. So there is a jet spray which loosens the fat, so there is no energy in the device. It loosens the fat just with the jet spray, and within the same cannula there is the irrigation and the suction. So this is Dr. Arbreiter from Germany. He does only fat grafting to the breast. So I was lucky to visit him almost 12 years now, 12 years back. So this is my certificate for the training for the Bewley workshop of the fat grafting, only to the breast. So this is the water jet cannula. So there are 5 settings. If we do the normal liposuction, we keep it at 3 and 5. The pressure of the water spray jet is higher, but for fat harvesting, we keep it only at level 1. So negative pressure, not the top at the -1, we keep it just half. The proportion of the clear oil increased if we rise the suction pressure. So the fats, they are destroyed and they form the oil. So we have to keep the low pressure. But if we keep a lower pressure than half or 0.5, it leads to frequent blockage of the suction channels and less efficiency in the fat harvesting. So cannula used is typically 3.8 millimeter. The rapid cannula, it is some nomenclature in the water jet, but there is only effective suction aperture is only 0.9 millimeter. So these narrow aperture for harvesting enables equally small fat cells which also integrate well while injection. And this is the fat processing already given by the company. So this is a advanced lipo collector. So there is a filter on the top which takes away all the fibrous tissue and the thicker fat. Then lower down there is again a seal that is 250 micron meter, in which the fat is at the top and the water will come down. So some authors, they propagate centrifuge, but excess centrifuge can destroy the adipocytes or fat stem cells. So this gives a combination of filtration and sedimentation. So we are avoiding the centrifugation. So washing destroys the microenvironment of the fat cells. So around the fat cells there are some collagen, proteins, enzymes, also the fibrin which stabilizes the adipocytes in the wound site is flushed out. So we are not washing. So fat infiltration is always done by a 1 keyhole incision or the 2 cuts, and mostly it is done in the subcutaneous plane all around the breast, 2/3 of the infiltration, and 1/3 is done below the gland or above the muscle or into the muscle. So we always avoid into the gland, so no infiltration has to be given inside the gland. So pectoral muscle injection is performed directly above the ribs while maintaining the constant contact of cannula with the ribs. So amount of fat grafting varies from 200 to 300 ml on each side. So the end point is by the touch, so you have to feel the breast. The breast should feel firm, not tense, to avoid pressure around the newly implanted fat cells.
So you put the fat in the upper pole around 250 cc. So this is fat grafting we always overdo. So 250 cc, so there will be some fat absorption. So we will be left with only 175 cc of the fat. So we have harvested around 400 ml of the fat. This has got a very unique filters which remove the fibrous fat. So this is the lipo collector. This is the high-end You can see we have filled this in 10 ml of syringes. And this is the blunt cannula. We are planning for only 2 cuts. So one is hidden in the upper part of the axilla. So we can put it in this direction. So we can put the fat like this. Second, for the crisscross or the second direction, we will take on the lateral crease, we will take the second cut. At different levels. At the level of the muscle, the level of the subcutaneous fat, and just below the nipple. So we do fat grafting equally in all the quadrants to the upper pole. So she has a flatter breast on the upper pole. So she has opted for the natural method. So you can see this, there is a projection on the right side. So left side is on the flatter side.
This is the beauty of the procedure. You can see the abdomen. So this is the liposuction effect on the flanks and the abdomen. So the abdomen has been carved. So post-operatively, a cotton bandage has to be done. We apply a lot of cotton pads so that the breast is not under tension for a few days and avoid pressure. The compression garment on the liposuction area. So wearing of the bra and avoidance of any physical exertion or exercise is refrained for 4 weeks, and oral antibiotics for 5 days, and avoid sleeping prone for 4 weeks. There is a lot of studies for the bioactivators. So there is a very huge brand called Cytori. They have isolated the stem cells. And I have also used from the Arthrex company. We can get the stem cells from the adipose derived from the fat cells. Then we put it into the fat grafting or sometimes the PRP. But all these studies I have done some research. However, this study is Peltoni et al. They proved that this method of stem cells enriched does not show any advantage over the water-assisted liposuction, but it incurred the additional expenses, loss of time, and increased risk of infection. Another study by McCarty concluded that stem cells produced are to be rejected in aesthetic surgeries due to the lack of clinical evidence. So what are the complications? Like, this procedure has some complications, no doubt. So first, most common is that there can be some induration which will subside over few weeks. Then persistent pain, hematoma is rare. There can be some nodular feel after maybe 4 weeks, abnormal breast fluid dysesthesia, and these are the fat necrosis and calcifications are the dreaded complications, but we have very rarely found them, and the cyst formation, breast infection, donor site infection. In one of my patients in the early practice, I overdo the procedure, so there was almost infection, and all the fat has come out. So this is again one session, 250 ml on each side, a long result. So there is rarely any reabsorption in all the studies. They take up to 6 months. In some studies it is 3 months. So there is no reabsorption of fat after 6 months. This is again one session. In fat grafting, we cannot change the shape of the breast. We cannot change the shape because the lower projection, the lower inframammary and all the circumference the measurements, they remain almost the same. Mostly we can fill the upper pole better. So what other things with the breast grafting is the composite breast augmentation. We do the implants and we can do 100 ml of the fat grafting on the same operating time. So we do both the procedures for augmentation. Then second is implant removal with mastopexy and the fat grafting, all three at the same time. And third, I also have the micro-air, so we can do before injection into the breast, we can do the expansion technique just by the vibration. This is expansion vibration lipofilling. And supplementation of the harvested fat, so we are not promoting this. There are so many studies with the stromal vascular fraction or adipose drive or PRP. Then there are many commercial processing devices, many high-end pure graft, lipogem, Tefla gauze rolling, but we are not promoting this. Thank you.
Thank you, Dr. Vikas. Nice presentation it was.
Can you show you a short video?
सर ने इत्थों मेरे कमर तो फैट ले लिया और मेरे इत्थों ऐस जगह तो फैट लेके रेस्ट च ट्रांसफर कर देती है और एक मिड लाइन वाली शेप दी है जिहड़ी कि मैंने बहुत ही वधिया लगा सो आई एम सो हैप्पी विद दैट सर थैंक यू सर थैंक यू मैम
So this is the beauty of the procedure because you are doing two procedures and you can offer your breast fat grafting to all the patients who are undergoing the liposuction in my initial practice. You can tell them why to throw this fat, we can use in other part of the body if they agree. Thank you.
Thank you.